Good morning. Today we'll talk about the pelvis. Now, basically, the bony pelvis is formed by the articulation of each of the two hip bones with the sacrum and midline behind and with each other in front. The greater pelvis is comfortably occupied by the abdominal viscera, leaving only the lesser pelvis for the pelvic viscera. The urinary bladder lies behind the pubis symphysis. The rectum and the anal canal are close to the sacrum and the coccyx. The middle space is left for the genital organs. Many structures cross the brim of the pelvis, that is, the brim of the pelvis is the curved line extending around the pelvis at the junction of the greater and the lesser pelvis called the linea terminalis. Right. The bony pelvis is formed by four bones united at four joints. So what are these two bones? They are the two hip bones in front and on the sides and the sacrum and the coccyx behind. The joints are the two sacroiliac joints, the pubis symphysis and the sacrococcygeal joint. The pelvis is divided by the plane of the pelvic inlet or the pelvic brim into a superior aperture of the pelvis into two parts. The upper part is known as the greater or the false pelvis, which lodges the abdominal viscera, and the lower part is the lesser or the true pelvis. The plane of the pelvic inlet passes from the sacral promontory to the upper margin of the pubis symphysis. The greater or the false pelvis include the two iliac fossae and forms a part of the posterior abdominal wall. The lesser or the true pelvis contains the pelvic viscera. Coming to the lesser pelvis. Now, lesser pelvis has the pelvic walls, which are made up of bones, ligaments, membranes, and muscles. The bony wall, they are formed anteriorly by the pubic symphysis and the bodies of the pubic bone, posteriorly by the sacrum and the coccyx. On each side are the two rami of the pubis, the ischium with the ramus, and the lower part of the ilium, forming the bony walls of the lesser pelvis. Now, coming to the ligaments and membranes, we have the obturator membrane closing the greater part of the obturator foramen and completes the lower part of the lateral wall of the pelvis. The sacrotuberous here, so the sacrotuberous and the sacrospinous ligaments bridge the gap between the hip bone and the sacrum and convert the lesser and the greater sciatic notches into foramina of the same name. Right? You can see it over here. The muscles of the pelvic inlet, we have the obturator internus occupying the internal part of pelvic part of the obturator foramen with its fascia reinforcing the lateral wall of the pelvis from the inside. And then we have this muscle over here, that is the piriformis, and its fascia forming the posterior wall of the pelvis also help in filling the gap of the greater sciatic foramen. Now, what is the pelvic inlet? Right? Now, or the superior aperture of the pelvis. The pelvic inlet is an oblique plane. Okay, this is the pelvic inlet, making an angle of about 50 to 60 degree with the horizontal plane, and it is bounded posteriorly by the sacral promontory and anteriorly by the upper margin of the pubic symphysis and on each side by the linea terminalis. So what is the linea terminalis? It includes the anterior margin of the ala of the sacrum, the the arcuate or the lower part of the middle border of the ilium, the pectineal line of the pubis or pecten pubis, and then the pubic crest. The pelvic inlet is heart shaped in male and widest in its posterior part. In the female, it is oval, widest most anteriorly than in the male, and posteriorly, the inlet is indented by the sacral promontory more so in the male than in the female. Now, this is the pelvic outlet or the inferior aperture of the pelvis. The pelvic outlet is bounded anteriorly by the arcuate or the inferior pubic ligament, posteriorly by the coccyx, on each side by the ischiopubic rami, over here, as you can see, or the side of the pubic arch, the ischial tuberosities, and the sacrotuberous ligament. Here, the sacrotuberous ligament. Now, the posterior part of the outlet is formed by the coccyx and the sacrotuberous ligament. It is mobile on the sacrum, and the sacrum itself is slightly mobile at the sacroiliac joints. Now, the pubic arch, this one, is formed by the ischiopubic rami of the two sides and by the lower margin of the pubic symphysis, which is rounded off by the arcuate pubic ligament. Now, clinical anatomy, the pelvis is a basin with its various walls and many openings. The posterior wall contains 5 pairs of anterior sacral foramina. The greater and the lesser sciatic notches are converted into a foramina of the same name with the help of the sacrotuberous, and the sacrospinous ligaments. Coming to the disposition of the pelvic fascia. Now, the pelvic fascia is distributed in the extraperitoneal space of the pelvis. It is converting the lateral pelvic wall and the pelvic floor, called the parietal pelvic fascia, and also surrounds the pelvic viscera, and here it is called the visceral pelvic fascia. You can see the parietal layer on the lateral pelvic wall and the fascia over the prostate, that is your visceral pelvic fascia. Now, principles of distribution. The fascia is extremely dense and membranous over the non-expansile structures, that is the lateral pelvic wall, but only loosely arranged over the expansile structure, that is the viscera, or over the mobile structure, that is the pelvic floor. As a rule, the fascia does not extend over the bare bones at the margins of the muscles. It is fusing with the periosteum. In this respect, the fascia of Waldeyer is an exception, which is extending from the sacrum to the ampulla of the rectum. We have done fascia of Waldeyer in the rectum. Now, the parietal fascia of the lateral pelvic wall. The fascia covering the muscles of the lateral pelvic wall is extremely condensed and thick to form strong membranes, closely adherent to the wall of the pelvic cavity and attached along a line from the iliopectineal line to the inferior border of the pubic bone. Here. Okay. Now, fascia covering the obturator internus is called the obturator fascia. It shows linear thickening or the tendinous arch for the origin of the levator ani muscle. Below its origin, it is closely related to the lunate fascia and to the pudendal canal. The fascia covering the piriformis over here is thin. The nerves over the piriformis, that is the sacral plexus, they lie external to the pelvic fascia and therefore do not pierce this fascia while passing out of the pelvis. Right? Whereas the gluteal vessels, on the other hand, they lie internal to the pelvic fascia and therefore have to pierce this fascia while passing out of the pelvis. Okay. That was the fascia of the pelvic lateral pelvic wall. Now coming to the parietal fascia over the pelvic floor. Now, the pelvic fascia covers both the surfaces of the pelvic diaphragm. As you can see, this is the pelvic diaphragm, forming the superior and the inferior leads. The inferior fascia is known as the anal fascia. In general, the fascia over the pelvic floor is loosely arranged between the peritoneum and the pelvic floor, forming a dead space for distension of the bladder or the rectum or the uterus or vagina. Because of this loose nature of this fascia, infections can spread rapidly within it. Now, however, in certain areas, this fascia is condensed to form fibromuscular ligaments, which is supporting the pelvic viscera. Now, these various we have studied them in detail in prostate, bladder, uterus, and rectum separately. Now, coming to the visceral pelvic fascia over the organs. Now, this fascia basically surrounds the extraperitoneal parts of the pelvic viscera. It is loose and cellular around distendable organs like the bladder, the rectum, and the vagina, but dense around the non distendable items like organs like the prostate. The visceral layer is attached along the line extending from the middle of the back of the pubis to the ischial spine. The greater sciatic foramen is basically the doorway of the gluteal region, and the pudendal nerve enters this region through the greater sciatic notch and quickly leaves it via the lesser sciatic notch to enter into the perineum. Now, the lateral wall also contains the obturator foramen for the passage of the obturator nerve, as you can see, which is supplying the abductors of the hip joint. Now, fracture may occur in the true pelvis, and fracture at this point, the fracture will be, if the fracture is at one point, it will be stable. In athletes, the anterior superior iliac spine may be pulled off by forcible contraction of the sartorius. Similarly, the anterior inferior iliac spine or the ischial tuberosities may be avulsed by the contraction of the attached muscles. Okay, now coming to an important point, which is the pelvic floor. Okay, so we did about the bony pelvis, about the lateral pelvic wall, the fascia over the pelvic walls, and the visceral fascia. Now coming to the pelvic floor, it is basically formed by the pelvic diaphragm, which is consisting of the levator ani and the coccygeus. It is resembling a hammock or a gutter because it slopes from either side towards the median plane, where it is traversed by the urethra and the anal canal, and also by the vagina in the female. The pelvic diaphragm is separating the perineum from the pelvis bone. Now, coming to the clinical anatomy of the pelvic floor. Now, pelvic floor is formed by the two gutter-shaped levator ani muscles supporting the pelvic viscera, especially during raised intra-abdominal pressure. The fetal head travels in the axis of the pelvic cavity. During the second stage of labor, the head of the baby, on reaching the pelvic floor, rotates from earlier transverse position into an anterior posterior position. The occiput moves downward and forward and reaches to about 80 to 85 degree angled pubic arch. Now, when the head passes through the anterior hiatus of the levator ani to reach the perineum and then it delivers, sometimes the episiotomy is also given to enlarge this perineum, and mostly the mediolateral episiotomy is given. Okay, so you have done this about the episiotomy before, right? Incision giving in the labia minora at an angle of 45 degree, cutting through the skin, the vaginal wall, and the bulbous spongiosum muscle. Now, injury to the pelvic floor, which mostly occurs during vaginal delivery, may cause uterine, vaginal, or even rectal prolapse. Appendicitis occurring due to pelvic position of the appendix may irritate the obturator nerve, leading to referred pain in the medial side of the thigh. Also, inflammation of the ovaries can cause referred pain in the medial side of the thigh due to irritation of the obturator nerve. These second to fourth sacral nerves and the coccygeal nerve can be anesthetized by an anesthetic agent put into the sacral canal. This is called caudal anesthesia used in obstetrics practice. Pain at the sacroiliac joint is felt on pressing the posterior superior iliac spine present at a dimple on the lower back. Okay, so we spoke about the pelvic inlet, the pelvic outlet. Now let's talk about the pelvic cavity. We have already spoken about the walls of the pelvis, now the lateral pelvic wall, how it is being formed, about the muscles. Then we did about the pelvic floor as well and its clinical importance. Now we'll talk about the pelvic cavity. The pelvic cavity is continuous above with the abdominal cavity at the pelvic brim and limited below by the pelvic diaphragm. Now the cavity, you know about the pelvic diaphragm we just discussed. The cavity is curved in such a way that it is directed downwards and backwards and then directed downwards and forwards, right? It is roughly J-shaped. It has unequal walls. We have spoken about how the lateral pelvic wall is being formed, measuring only about 5 centimeter anteriorly and 15 centimeter posteriorly. The cavity is more roomy or larger in females than in males. You are aware of this. Very important contents of the pelvic cavity. We have the sigmoid colon and the rectum, right, occupying the posterior part of the pelvis. We have the bladder that is lying anteriorly, the prostate lying at the neck of the urinary bladder. In between the bladder and the rectum, there is a transverse septum or genital septum made up of connective tissue in males. In this males, the septum is small, contains the ductus deferens, this is the ductus deferens, the seminal vesicle, and the ureter on each side. In the female, this septum is large and it contains the uterus over here, the uterine tube, the round ligament is the round ligament of the uterus, the ligament of the ovary, the ovaries, the vagina, and the ureter. Very important enumeration question. Structures crossing the pelvic inlet or brim of the pelvis from the posterior median plane, sweeping laterally and then anteriorly. We have the median sacral vessels, you can see over here. Then we have the sympathetic trunk, the lumbosacral trunk, the iliolumbar artery, this is the iliolumbar artery, the obturator nerve, you can see this is the obturator nerve running in the obturator canal. Then we have the internal iliac vessels, the medial limb of sigmoid mesocolon with superior rectal vessels on the left side only. Then we have the ureter over here, right? Sigmoid colon on left side only, ovarian vessels in females, ductus deferens in males or the round ligament of uterus in females, the lateral umbilical ligament, the median umbilical ligament or the urachus, the autonomic nerve plexus, coils of intestine and the pregnant uterus, and a full bladder. Right?